Bismillahir Rahmanir Rahim. Ahlan wa sahlan to our technology and medicine session. Inshallah, we'll have some intellectually stimulating talks for you all today. Before I begin, there's just a slight change in the scheduling. So instead of the poster session, we're going to be hosting a trainee professional development and networking session, inshallah, for medical students, residents, and fellows at 5:10 p.m. in the Pheasant Ridge Auditorium upstairs. So all the trainees are encouraged to attend. So our first speaker, Dr. Ammar Mandvi, completed his family medicine residency training with subspecialization in tropical medicine, and then pivoted to technology and embarked on a transformative journey in clinical informatics, where he completed a UCSD clinical information or informatics fellowship. So in this role, he was part of a clinical design oversight committee and then was involved in initiatives like the Center for Innovation Health at UCSD Health, and that included cutting-edge AI platforms and optimizing clinical workflow. His work extended to enhancing patient lifestyle and integrative medicine programs, and implementing quality improvement measures for inflammatory bowel disease and prioritizing epic builds for various clinical subspecialties. Currently, he serves as assistant clinical professor in family medicine at UCSD, and his main focus in research is exploring artificial intelligence and machine learning applications in primary care, with a 5-year grant he has from the American Board of Family Medicine. His focus has been in finding ways to incorporate AI into screening, diagnosis, and management of chronic diseases. So Dr. Mandvi will be speaking on artificial intelligence in medicine. Please join me in welcoming Dr. Ammar Mandvi.
I want to first thank the Saifi Burhani Medical Association of America and Canada. I guess you can see the flag there too, but for allowing me to talk. This is my first time here at this conference, as well as my first time speaking at a CME. So apologies for any errors I might make or if I'm talking too fast. I also want to secondly thank whichever person put a loto in the Betul Kala. Really appreciate that. It's the little details to this conference that really matters, so thank you. A lot of people have approached me saying like, oh, you're the AI guy, you know. Just a little background on why I chose informatics. It was in my residency program. I was really frustrated with the EHR, the note writing, the fact that I was spending 30 minutes on the computer and 10 minutes with the patient. It was very frustrating. Along with my colleagues next to me, suffering, one of them almost threw their laptop at the wall. And so all of us here are here to help our patients. But who's here to help you? And so that's why I took on, with a lot of convincing with my wife, to do another 2 years of fellowship to get an understanding of what the EHR does for us and how we can be a partner with the EHR rather than constantly battling with updates, clinical decision support, you know, all that stuff. So here I am now, you know, designing workflows, implementation, efficiency, and focusing on physician burnout. And as many of you are aware, AI has been booming. And so when I was asked to talk on that, I wanted to educate all of you on what AI really is, the many forms of it, and then how we can use it and how we can learn from it. So the first part of it will be a little dry. I don't know if there's chai in the back or coffee. Please feel free to grab some before I begin. But without further ado, I'll go ahead and start. So I have no disclosures to make. And the objectives here are that I want all of you to understand the fundamentals of AI, to explore the applications of AI in healthcare. You know, there's diverse ways that AI is transforming medicine, from enhancing diagnostics, image processing, as well as optimizing administrative processes too. I'll provide some real-world examples, looking at concrete examples of AI integration into the medical practice from Google's DeepMind, as well as to virtual health assistants. And then also understanding the benefits of AI in medicine, discover how AI has driven advancements to improve accuracy in diagnostics, enable personalized treatment plans, and streamline healthcare operations too. And then with also understanding the challenges and the ethical complications that can arise with artificial intelligence. Just like any medical device that is implemented into a hospital, there's a lot of testing that needs to go into it prior to having it released. Similarly, AI and machine learning has to go through the similar process too, and it's a very, very cumbersome, complicated process. Everything is very new right now, so all of this is a very pioneering feature, and it's quite tedious to go through. So that's the dry part of it all. Give me 1 second. I'm just going to maximize my window here because I am losing my vision. Let's see. Okay. So by the end of this presentation, participants will be equipped with a comprehensive understanding of AI, its role in medicine, its benefits, its challenges, the ethical considerations, and then empower you to be knowledgeable in artificial intelligence so that when you go back to your private clinic or your academic institution or your research area, you'll understand what AI will play a role in your specific practice. And I guarantee you, every specialty here, there will be some sort of AI talk, except for dentists. I'm sorry, I left out a slide, but just think of radiology as the same thing. So for those that have questions through the presentation, if you don't mind scanning the QR code, saving that on your browser, and if you have any questions during my talk, I'll have a live feed on my phone, and I can answer them if time permitted. So here's the quick outline. First is understanding what AI is, its implications, applications, benefits and challenges, directions, and ethical considerations. So first, the basics of AI. So try and keep your eyes open as much as you can. But everything revolves around the simulation of the human brain and the intelligence process that we have, but we're trying to recreate it with machines. And so creating these algorithms enables machines to mimic these cognitive processes that we have every day. It goes through reasoning, problem solving, and decision making. And so these components of artificial intelligence, one component is machine learning, which is to learn from data and improve that learning from repetitive data inputs, and its ability to learn over time. So it can recognize patterns and make predictions and decisions without the need of explicitly being programmed. And with that, deeper into that is deep learning, which you probably heard of through the news, et cetera, ChatGPT. But this is a more complex machine learning model inspired by the human brain's neural network. And it involves complex layers of neural networks that learn representations of the data. And when you get into that, there's deeper neural networks which are used to process images, speech recognition, as well as emotions and behaviors just through video. But all of this that you see here, the main foundation of it is data science. The data that you use is important to create the model as well as get the result from it too. So here's a simplified version of it. You have the data that you've compiled, you create the model, and then you get the result. Now, there's the whole term garbage in, garbage out. If you don't have good quality data, then your model will be great, your result will be horrible, meaning it might give you a false positive or a false negative, or provide the incorrect information for you while you're talking to that patient, and the AI machine is saying, hey, I think this patient has a PE, when it's really just a knee injury. So these are things that we have to consider when putting in the proper data to our models. Similarly, if you have really excellent data, But a horrible model or the wrong type of model, that's also trash, and the results will also end up being garbage too. So that's also a consideration we have to take in. Now, let's say your data is great, it's good, clean data, the model is also the appropriate model to use, but your result is still garbage. That means that your model that you've created does not have that clinical impact that you were looking for. Let's say a cardiologist, we develop a machine learning algorithm to detect heart failure in a patient. And you get a little notification on your computer saying, hey, all the data we plugged in, this patient has a risk of heart failure right now. Is that cardiologist still going to order a BNP, an EKG, an echo? Probably. They're not going to go just off of that data model to say, hey, we should probably start you on up your Lasix or however you would manage CHF. So really, if the result doesn't change, then there's no point in implementing it into the practice. So that's also something we have to consider too. And so for this whole technological evolution, that we have to recognize the significance of data quality, diversity, as well as the ethical considerations that mold the future of these AI models into our practice. So a couple myths that I wanted to debunk. More data is all you need. Okay, I'm here at UC San Diego. We have millions of data points because we have clinics not just in San Diego, but in Temecula, as well as Chula Vista. We also stretch out to Irvine. That's great. We have great amounts of data. But if the data is not clean, if it's not correct, that can be problematic. One example I can give you is, let's say we want to create a machine learning model, and one of the data points is an A1C, okay? Well, do you want the most recent A1C? Do you want the average A1C? Do you want a 5-year time span of A1C? What if the A1C back in 2015 is different from the A1C today? How does that matter, and how does that make a difference? And so it's not just the data, but the time of the data, also how the data is collected. At one institution, I know for mine, it's glycated hemoglobin, and that's how the data is labeled. Someone else's lab might be hemoglobin A1C. Someone else's institution might be hemoglobin space A1C. And to search for that data is very, very difficult. And so there's a lot of processes that come in place with that. An accurate model is all you need, which is not true. You need it to be usable, useful, and incorporate human factors as well as operational considerations. Like I had mentioned before, let's say you have a good model, but it doesn't really do much. I already know that answer of the patient. He's already in an exacerbation. Why are you telling me this? So understanding that is a model useful at that point is also important too. And then same with the result. A good result is sufficient for a clinical impact. This kind of goes overlapping with that model effect is, does the system that you are working with and the product that you have, is it reasonable? Is it self-sustaining? A lot of these machine learning models learn on itself, meaning that the new data that you put in, it'll constantly learn and mold. Just like our brains are plastic, we will also mold to different adaptations to different information. So there has to be some sort of governance process in place to make sure that this model is working accurately. You can't just set it and forget it. So once again, the role of data, we have two different types of data. They have structured data, unstructured data. There's predefined data fields. These are usually stored in databases like you would see in your EHR, A1C, blood pressure, cholesterol levels, et cetera. These are mostly numerical values. And then you have unstructured data, which are more imaging, speech recognition, and your progress notes too can be one consideration. And then within that, you have continuous and non-continuous or categorical. Continuous would be numerical values like temperature, height, and then categorical would be like gender or country, zip code, area, like that. So, I don't want to get into too much of the weeds of this, but like I said, there's a lot of importance in the data, and that's the foundation for these machine learning algorithms and AI. So a lot of physicians will be like, okay, just throw AI at that. I'm like, you don't understand. There's so much more that just, you can't just throw some type of model and let it work. There's this whole process that has to go through it, along with scaling and data landscaping too. The data storage, where is it going to live, security of it all too, because this is patient information that we're using to learn our machine learning models for. So if that is compromised, then the institution itself will be in big trouble as well. So let's say now I've trained you on how to build a machine learning model, right? All good? Makes sense? Let's say you have your patient data here, patients 1 through 6. Obviously, that's way too little of data, but usually some of the algorithms we have are 600, 800 patients of data points. And so we have glucose, BMI, age, gender, blood pressure, and the outcome is whether they have diabetes or not. So these measurements of glucose, age, BMI, et cetera, these are the features, and the observations are these patient rows here. So we have 6 observations, and then the outcomes are these targets. So this is the basics of the machine learning model that we'll use and extract that data. Once again, what factors might influence that, the problem you're asking, as well as what data do you have? Let's say you go back and for some reason your clinic doesn't have glucose levels, or your clinic didn't calculate BMI properly. That data might be missing, and so that's where you have to understand which data is important and which data do you actually have. Not all EHRs are structured the same way, and these discrete data points, once again, can be labeled in very, very different ways too. And so with that, we've expanded our decision tree here from, instead of just data, model, and then result, it's a little bit more elaborate, where there's the data collection, feature extraction, model selection, and then training that model on previously already collected data. Because you can't just release your machine learning model into the wild and expect it to learn on its own. Just like you would with Quran, you're going to memorize some words, you're going to understand some of the Arabic, and then you're going to learn more from that as you go on. So similarly, you want to train the model and then validate it too by testing it, which is all part of the HIVS curriculum too. After that, then you're going to go out and test yourself and use that knowledge and use the prediction models and validate it too. So evaluate it. Once that's done, it's going to do this whole feedback loop, because remember, all the new data that's coming in for these newer models are going to be tested again, and again. So more complicated stuff here with the machine learning part of it. Arthur Samuel had, one of the pioneers of computer gaming and machine learning. He was one of the first people to invent computer checkers, and that uses a lot of algorithmic approach. And so you have these predictions, classifications, or decisions, and all of this is learning from that data. And there's 3 specific types of machine learning model data that I wanted to talk about. There's a lot more that we can go into detail for, but I don't have that time. In terms of supervised learning, that's trained on labeled data and mapping inputs to the desired outputs. And then there's unsupervised data points, which is finding patterns within that data. And then there's reinforcement learning, and the big picture here is just think of Tesla. When it's doing the self-driving cars, it's rewarding itself when it does a right move. So, okay, I merged to the left and I avoided an accident. I'm going to learn from that next time. That the next time I do merge, I'm going to avoid that accident, and so it reinforces that type of learning. So for supervised learning, these are where you're guiding the computer to make smart choices. And a very, very basic example right here is, let's say I have these fruits and or just vegetables. I guess you can argue that tomatoes are fruit, but tomatoes, carrots, and bell peppers. Obviously, I know that, but the computer will not know that. It's just going to see that as something red, something orange, something green. So I myself, as a user, will be labeling these items as a tomato, carrot, bell pepper, using descriptive factors. A tomato is red. It's got a little bit more sweetness to it. Carrots are a little bit crunchier. Bell peppers are green, and they're a bit larger. And so I feed that all into the computer, I make my model, and then I test it now. So now I'm going to give it a brand new carrot that it has not learned from this previous data, and I'm going to ask it, well, what do you think it is? And so the question is, what do you think the vegetable is? And it's going to pop out these answers for you. That's the basic model of a supervised learning model, machine learning model. The main importance of this is the iterative process. So let's say it got the carrot part wrong and mixed it with the tomato. It's going to go back again and learn from new data points too. And so with supervised learning, this is the patient example. Let's say you have these patients again, and you have a lot more patients because you need a lot more data. it's going to do that similar type of data modeling too to find that this type of patient has this type of risk, et cetera, et cetera. And then for unsupervised learning, this is more of a clustering problem here. So going back to the vegetable idea, you have tomatoes, carrots, and bell peppers, but it doesn't know what it is at all. It's going to go into the model, and then it's going to categorize all of the vegetables. So it's going to know that these long orange things are one thing, these green things are another thing, and then the tomatoes are another thing too. So these are the main differences there. One medical example is with these unsupervised learning, the human can make their own our own conclusions from this data. So going back to a patient example here, just looking at it quickly, can you find a pattern? Probably not. So with machine learning, it's able to categorize that these green ones are a little bit healthier than the red ones, and you can see based on that, like their cholesterol levels are a little higher, and then you have the moderate one with the cholesterol levels a little lower. Their blood pressures are a bit better controlled on the green ones, and then they have risk factors that they consider as well with age. So this type of unsupervised learning is good for categorical pattern recognition. So one of my studies that I've been doing at UCSD is also understanding the physician's attitude and perceptions towards AI in medicine. And so we did a little group survey for our primary care groups in San Diego, and we asked them, well, what are your thoughts on it? Overall, this paper will be published in about 2 weeks or so, but it's optimistically skeptical or skeptically optimistic, however you want to phrase it. The main importance that I found was that the physicians didn't want their autonomy and power to be taken away. A lot of these models or things that do come into play, let's leave AI aside. It's all about revenue, saving money, patient efficiency, patient safety, et cetera, but there's not a lot of things for the physician. How is it helping me? And if it helps too much, then I just get bombarded with all of this help, and I can't really decide for myself. So that's where the study came in, and we found that understanding the end users are really important for understanding the AI model that you want to create too. This is another example of a gradient-boosted decision tree, which I will ask you at the end, but this is our obstructive sleep apnea prediction model that we're creating. The data features are demographics, chief complaints, problem list, med list, vitals, and recent labs. And the data outcome is the sleep study test that we have at the very end. Remember, these are all data points that we've collected from the past. So these are patients that have this data and have had a sleep study. So now we're telling our model, okay, learn from this and tell me if I give you another set of patients with kind of different demographics and discrete data, would this patient have a risk of OSA or not? So what's happening here is that it takes the data and then it creates the algorithm, and then it tests itself. It's going to learn from itself and then incorporate the data as new data and then keep fine-tuning it until it gets to the right decision tree that it needs to make. And then we compare that to our actual data points and see if it actually makes sense or not. So with that being said, all the dry talk, would you say that this is supervised or unsupervised learning? So this would be considered supervised because I gave it all the information here as well as the data outcome, okay? And then you could change it up and say, okay, just list all the patients that have, I'll leave that example for another lecture. Here's another question that is very famous, this publication. Is it a Chihuahua or is it a blueberry muffin? This is pretty cool in computer science, to understand image processing. I asked my 3-year-old, about to be 3-year-old, is this a Chihuahua or is it a muffin? And midway through, she was just very hungry for a muffin. So it didn't really work out, but she was able to distinguish between a dog and a muffin very quickly for a 3-year-old, right? But for a computer, that's going to take some time. There's so many details. Like, if you didn't have good vision, you would probably think that that's a Chihuahua. There's little blurred lines around here that's very similar to the blurred lines around the eye here. So, when it comes to image processing, it can be very difficult, very complex, but this is one funny example that I saw that, could be used as an example for X-rays, MRIs, And I'm sure a lot of radiologists are seeing a lot of software in the industry right now too. I'm going to skip this slide right now because it's a little too detailed. Now for the neural network, what's the neural network? Neurologists around here? Great. You mind just stepping? Okay. All right. So as we mostly know, there's the dendrites, the nucleus, the axon, and then the terminal branches there. And so very similarly, we try and create our neural network to behave that same way, except the output is more of a probabilistic fashion. And so they have different weights to them too. And so I expect this is one of the CME questions, to memorize all these formulas and then answer them at the very end, okay? But this is a very similar interpretation of how it would be mathematically. And so what you can do is, you can tune some of these areas in the synapses as well as the output axons, and all in all, it creates this wonderful, nice little neural network and a decision tree from that. And then, so here's a quick review of the basics here. So right now you have traditional learning, which you have the raw data, a little bit of human knowledge, right? Like I said, if I'm going to test a machine learning algorithm for OSA, I'm not going to put other data points that might not seem relevant. I want to put, if they have hypertension, if they're smoking, if they're obese, maybe their neck circumference. Once again, that's a question I have to ask. Is that neck circumference data even in my chart? I don't know anybody else here besides maybe anesthesiologists that might measure neck circumference. So that's something, a data point that we would need to find, or the Mallampati score. That could be one of the things we could look into too. But the raw data with the human knowledge, we produce a model, and then we get that model right there. Now, the deep learning part of it is just raw data, like I had shown you with the pictures there too. The raw data is, the deep learning is going to learn on its own through this neural network, and it's going to create a model for us. And then same when you get into the learning from that deep learning, the raw data going to the model, you see here there's this missing gap here, the feature engineering, that model, the creation of it. You might have heard of that black box of AI. That's what's missing here. We have trouble going under the hood and saying, how did you get to that answer? Like, how did you discover that this correlates to this? And so that's where a lot of the ethical considerations come into play, is when you release a model, but you don't understand how it works, it's very tough, because if there is patient safety involved, it can be very problematic. And I'm not a lawyer, so I don't know how that would really work out in the court of law if you're trusting an AI system and it tells you something very confidently, but you can't explain it. And then the other thing is, for the learning from the deep learning, we have the raw data, it goes to the model, and then we try and interpret it. And that's where I'll show you one example of how we can interpret it and then add more of that human knowledge into our database too. So from code to clinic, that's what I like to tell my medical students and residents. There's that data part of it. The myth is, okay, we just need a lot of data, but really it's about the quality of the data. With the people, it's not just me. I know I'm talking and it seems like very dry, but there's a lot more that goes into play. It's all of your voices, all of your opinions. You guys are the end users of how you want to use this model. And if it's not working for you, then we should not be making it. Your institutions, if they're not collecting that right type of data, then it's going to be difficult to do too. As well as the readiness, is your institution ready to establish that? The integration of the AI too. Let's say you have a current workflow in your clinic and then you throw in AI as part of a step for a check-in process, and the nursing is like, well, what is this? This is just disrupting my routine. That's also an issue too that you have to consider. And then the post-launch too, making sure that you have some type of AI governance and process to make sure that it works. The applications in medicine, there's diagnostic and image analysis, treatment and drug discovery, predictive analytics and early detection, and the administrative and operational efficiency. So this is all the good stuff here, now that I taught you the 101 of machine learning. So with diagnostic and image analysis, it goes anywhere from radiology, ophthalmology, digital pathology, dermatology, cardiology, and even scoping with GI endoscopies or even within surgery too. All of this is, I'm sure you've read it in your own specialties, but there's also novel signals that we can find from these deep learning algorithms, such as cardiovascular risk. We can even predict age, sex, systemic disease, kidney functions, which I'll show you a few papers on. So at UCSD, we were one of the first to discover this deep learning method to detect COVID-19 in just chest x-rays. And we use this heat mapping area right here to see if these patients would have COVID-19. Now, for any radiologist, you might not be able to see it as adequately, or maybe, sorry, that might have been offensive. For any other primary care doctor, we might have missed this, or in the ER. But then what they had done is, like, let's say this heat mapping was done and it did detect COVID-19. We would do a COVID-19 test and actually find out that this patient was positive for COVID-19. And so we were able to actually treat this patient much differently than we would if we didn't know that it was COVID-19. Another example here is, for mammography studies, it's able to detect mammographic findings much quicker and at a more precise level, but obviously with the need of radiologists to assist in that too. For my ophthalmologists out there, this recent paper predicting sex and age from from OCT readings. I don't know any ophthalmologist that can detect sex in a patient just from an OCT reading. And if you are, that's pretty cool. But this is the vast data that we can incorporate and it can learn from to just detect gender, age, systemic diseases from these image processings. Here's another example that I thought was pretty cool. Google had taken thousands of pictures of these patients' eyes, and they were looking at cataracts specifically. But what they found was that the dark pigmentation here was something new that the deep learning algorithm was able to detect. And from previous studies, they were able to connect that Mobius gland disease is associated with diabetes. And so what we might initially were looking at with cataracts, we found something much different, which was the darkening of the eyelids there too. So a lot of these discoveries through deep learning can be very beneficial and enhance our learning for our diseases and patient management too. Here's one for the cardiologist or anyone else out there. Can you read this EKG for me, Ron? Okay, cool. I'll assume that's right. But what are you missing? Predicted ejection fraction. Would you think that an EKG could predict an ejection fraction? No, right? But with these image analyses, with thousands and thousands of EKGs and patient data associating with that, it can find ejection fraction prediction too. Once again, it goes back to, well, is it the right thing to do? Let's say you do have a patient with a CHF exacerbation and it gives you this ejection fraction. Are you really going to trust it? Are you really going to use that to manage it? Or are you still going to order that BNP or that echo, et cetera, et cetera? So those are all things to consider. Just running through a couple more examples for my cardiology folks out there, detecting EF in just a one-lead EKG on an AI algorithm for a stethoscope. So what they do is they're able to place it on different areas, do the EKG, because I think there's leads there, and then through its algorithm, it's able to predict ejection fractions too. And this is incorporating both AI as well as the clinical decision support. So it's able to detect the EKG and the echocardiogram. So it's gone beyond that and combined both models into this new type of product. I think it's out tested in the UK, but hopefully it might come in the States too. Now for the treatment and drug discovery, this is one for the genomics and the scientists out there. This AlphaFold company is an AI system developed through DeepMind, where it's able to sequence these proteins as well as provide a prediction on which protein would be helpful in creating immunization. So this is one example of a T-cell immunomodulator protein for the Plasmodium falciparum that causes malaria. And so we're able to detect this type of protein and see if we can attack it using antibodies in specific categories and create a vaccine from that. So this is all through machine learning and algorithms as well. Another one is machine learning for prediction of sepsis in the ICU. One of my advisors, Dr. Shamim Namadi, had created this, which has gone live. And so it's kind of like a minority report thing where we can detect, oh, this patient might be crashing sooner than we think. And so we get this alert and we keep our ears closer to the ground to make sure that this patient doesn't crash. Another one is for glaucoma using data from All of Us research program. where all of us is a data set that's free and accessible to everybody. It's all de-identified data. So if you want to practice creating your own machine learning algorithm, you can go to all of us, register, and use these data points that are all, like I said, they're all discrete data points, and they all have the same values, and so you can create your own model that way too. And so they used risk factors that are common in glaucoma and finding out which ones are highest risk versus less. And then, sorry, I think I'm a little short on time. Another one is an approach to continuous prediction of future AKIs. So right here, you can see this is a typical stay for a patient. And at this point here, day 6 is when they have that AKI. Now with predictive analytics, this model was able to predict it 48 hours before the AKI even happened. So if anyone has seen Minority Report, this is very similar to that. And we can prevent these injuries from occurring with these alerts too. And then the other one I wanted to talk to you about was this scalable and accurate deep learning. Right here, what you see here is a collection of a synopsis of a patient that was admitted. And it didn't go well for the patient. I think this patient had breast cancer, metastatic breast cancer with a right lung malignancy, complicated by an effusion, and a right lung empyema, needing a right lung pleurax. Pulmonary consult note was done. Radiology was done here. And so this machine learning algorithm was able to pull all that out and predict a mortality for that patient. And so, this is also helpful in discharging needs to make sure that this patient doesn't return or have worsening outcomes too. Another one, predicting medication orders. So let's say you have an admission for a patient, and it can already tee up medications for you based on that patient's demographics, history, et cetera, et cetera. There's so many examples that I'm trying to touch on everybody's specialties right now. The nice thing here, though, is for whether you're a physician, nurse practitioner, or working in the office too, but the administrative and operational efficiencies. This is what's really, really cool right now. Anyone have an actual scribe with them or use a scribe service? Okay, so you have someone that comes in, they might call out sick, et cetera, et cetera. Now with these scribe services like Deep Curai, Deep Scribe, Nuance, Augmetics, they use what's called ambient listening. And it's able to create data from that conversation you're having with the patient, create the subjective, the physical exam findings, as well as the plan, all in one. And so UCSD is testing this out right now, and we've improved note efficiency, and it takes like 5 minutes for a note to be done. So pretty cool stuff. This is where I really enjoy it because it's the physician burnout part of it. It's the note writing that gets me, and I'm sure it gets all of you too. This one was a Wall Street Journal post that was done where ChatGPT was used in messages between physicians and doctors. Physicians and patients. And so what they did was they generated a draft reply when a patient asked a question to the physician just through their portal. And it was able to give a sort of nice response, but the physician had the ability to edit that draft. What was really helpful in that is, it created more of that empathy part of it, because for me, I'm like, yeah, your labs look fine, keep doing what you're doing, and that would be it. Obviously, I'd be a little bit more empathetic than that, but just for the sake of time, I'm telling you. But with ChatGPT or these large language models, they would provide a little bit more of that soft touch. And so patients were a lot more satisfied with that outcome too. We also did a study where we compared physician and AI chatbot responses to patient questions, and then we posted this on, I think, Reddit, and to see what their outcomes would be. And so one of the questions here was, hold on, let me read it. It was just a clinical case scenario, and right here what you see is the physician's response, kind of dry, bullet pointed here, but with ChatGPT, it created this nice little paragraph and provided a little bit more empathy to that answer. So it sounds a little crazy, right? But a lot of patients were satisfied with those responses. We had a few physicians that graded these responses without knowing whether it was an AI or a physician, and actually preferred that they have these answers sent to the patient. So the main thing I wanted to explain here is it's not really about the content. Obviously, you can spend that time and think about, oh, I'm sorry, Mr. Frank, that must be really hard for you to, go through the side effect of this medication. Here are some options for you, et cetera, et cetera. That might take a lot of time. The main thing that we were able to find from the study is that it saved the physician time, as well as added that empathy component to it too. In-basket is a burden on everyone here, and so these types of tools can be very, very helpful. Another one example is for cardiovascular disease and severity. Like I said, using machine learning models to predict aortic stenosis from left ventricular outflow obstruction. It was able to determine with a positive predictive value from 59% to 99%, and able to also grade from moderate to severe as well as mild cases too, just with echocardiograms. So, quick summary on large language models. What is it and how is it related to ChatGPT? What you might think of is words that are actually defined as tokens. So you know how they say the quick brown fox jumped over the lazy, no one knows that? Dog, okay? That's that one sentence where you use all the letters. So predicting that next word is pretty much what ChatGPT is doing. It's using your previous sentences to predict what that next word is. And that's the basic foundation of these large language models, and it's using these networks to gain contextual understanding. Oops. And then I'll skip through this. Benefits and challenges. Obviously, we know the benefits I've told you a lot about. We have to obviously test these models very with scrutiny and with a magnifying glass because we don't want anything to go wrong. But there are downsides to it. I don't know if you've seen this article, but OpenAI used Kenyan workers for less than $2 per hour to make ChatGPT less toxic, so just unfair pay. There's a little harm to the environment just because of the data processing and the computing power it needs. It costs a lot of money to power these servers. And then who's liable, right? That's the big question. Let's say some large language model tells me to do this and I follow it and something goes wrong. Is it my fault for saying that, hey, you should follow these instructions? Is it the institution's fault for putting this out there in front of me to say, hey, you should probably suggest this to the patient? Or is it the company that's made this product for you? So there's a lot of question into that. Ultimately, it always goes down to the doctor, but we are ultimately the main ones to finalize that decision as of right now. Some of the challenges, this one recently came out, with image processing. There was no difference between an AI scoping for an endoscopy versus a GI to find for polyps, whether they're cancerous or not. So there's probably still needs advancing and fine-tuning, but right now, GI, you still have your job. And then, bending the patient safety curve. How much can AI help? Is AI needed for everything? No, it's not. It's only needed when you feel like you need that help, that assistance. And so, when I put the slide together, it's all about predictions. We might have some sort of gestalt. We should probably do this. We should probably not do this. Same with prediction models too. I have this percentage of this happening. When I was, flying here, I thought, okay, well, the pilot's telling me, good afternoon, this is flight 2230 from San Diego to Dallas. We'll be landing at 11 p.m. With a 90% chance of landing successfully. No pilot's going to tell you that. So it's all about predictions and understanding that. I would hate to have a pilot tell me that. And then also understanding the current workflow, like I had mentioned. You might have a great practice, super efficient, in and out. Patients are seen actually on time, discharged on time, and all of a sudden, there's this new AI model that you have to implement and incorporate into your workflow. Is that going to slow your process down, even though it might have helped you with data aggregation, a quick little summary from the full chart that you have to go through? So understanding those challenges are important too, because if you don't accept it, then you're not going to use it, and you're just going to fight against it, and my job is useless then. So this is one example. Some patients were doing, I think, OCT testing, and so they had to go through this whole process of checking in, taking the photos, maintaining the images, sending them out, having the ophthalmologist read it, and then giving it to the patients 2 to 10 weeks afterwards. And this was not in America, this was done in Thailand. But with AI, you can do it within 10 minutes. So obviously, this is a very promising AI implementation because you're able to incorporate it right when you see that patient rather than waiting. I already talked about most of the ethical considerations, and I talked about this too. One thing I think it would be really important for all of you to just take a picture of, for the students out there, for those that really want to learn about artificial intelligence and machine learning, this is a great guideline on how to read articles that use machine learning. It's very stats heavy, but that's what we use, right? It's all data. I would really recommend everyone to review this literature too. And with that being said, that's all I could give you with AI in medicine in 45 minutes. But I want to leave you with this one thought. Did I lose my job? The answer is no. Physicians who use AI will replace those that don't use AI. Just like you would use your EHR to take care of patients. The data is great. The way you can document everything is amazing. Obviously, it's going to beat paper charts, but we have to adapt to that change. And just like, it's called practice of medicine. You're always practicing. You're never going to be perfect at it. And so with the adaptation of technology, we also have to learn from that too and learn with that as well. And then my final statement is, a machine does not have the warmth and compassion of a hand when you put on someone's shoulder that's crying, that's lost a patient. Or it doesn't have that smile when you've congratulated that patient for the amount of exercise they've done or the amount of weight they've lost or how happy they're feeling with the interventions that you've provided for them. And it'll never build that relationship that you have with your patient today. So I want to leave you with that thought. You're not going to lose your job, but hopefully these AI programs, these models will help you in your future, in your practice. And one more thing for the medical students out there, for those that are in education, if you're applying to medical school or any type of schooling, I highly encourage you to look at the syllabus and see if informatics or data science or artificial intelligence is incorporated into the syllabus, because by the time you graduate, this will be there for you to learn and use. And so, like I said, nothing will replace you. And with that, here are my references and any questions.
We have time for just one or two questions. So,
Ammar, thank you for an excellent talk. Quick question: you mentioned you guys are working on OSA with your AI software. So, quick question: I know you kind of mentioned about imaging, and then you said it's difficult for image points. But I was wondering, are you using any kind of imaging, or if radiology reads from images, whether it's CT scans or looking at lateral cephs for the airway, and using those as data points as well, or are you only looking mostly at clinical work and lab works for determining?
Yeah, that's a good question. At this point, we just got this grant, so everything is new, and so I'm setting up staff and resources. Right now, we're just using these discrete data points. So like those charts I told you of BMI, blood pressure medications, cholesterol medications, et cetera, et cetera. Those are things that are very easily extractable. With image processing, that's a little bit further, a little bit deeper in learning that I'm still learning about, and I know I need to find the right people to understand that type of data, but that, we can talk offline or off stage and, see how these types of imaging could be helpful in detecting OSA as well as its severity.
for time constraints, we'll take one more question.
Nice presentation. I just wanted to ask a question. You showed a slide about AI being able to predict heart failure from the EKGs. So do we know what the AI sees on the EKG that tells them it's heart failure, or we don't know that yet?
That's the black box that I was mentioning. Is it's able to process all of these images and find some sort of pattern, but we can't go under that hood and say, oh, that's the reason why. It's everything that's happening in V1.
And the the AI can't tell us what it's seeing or what pattern it's detecting.
Not at this time. Yeah. I mean, if there's any computer scientists out there that would probably know or understand that better, but that's that black box that we have to be careful about. That's why if this EKG thing with the ejection fraction was released, it's very hard to tell whether it's accurate or not. Yeah. So, thank you very much. Here's my little QR code. You can text or email me if you have any other questions. Shukran.